coming from.
Hey, Lindsay, I got a message from you privately, and you see this, and I say, I can see it.
Yay, okay, so that should be where your chat box is. And there should be like a little gray writing, type message here below that.
Down here.
And everyone, as you're settling in, go ahead and mute yourselves for now.
Vida, I want you to take a shower, okay? I'm gonna be there. I have a trainee. Hey, hermoso. Flaco. I have a training. I'm gonna be in the office.
Great, we're going to get started in just a minute.
Oh shit, where is my thing here?
Okay, welcome everybody to the first annual PC Care Summit. Oh, this is less fun when I can't hear anyone. But I imagine you all screaming and your kids coming into the room and they're saying, why are you yelling? And you're saying, because I'm so happy. I'm going to just envision this and it's going to be great. So as you are continuing to come in, please put your name and where you're coming from in the chat bar. And we're going to go ahead and get started. So as we get started in our day, I would like to take a moment of mindfulness to just help us all be aware of who we are and where we are. So we're going to start by taking 3 nice big breaths together. So go ahead, find a comfortable seat or stand up, nice tall back. And everyone, you can close your eyes or find somewhere to look. And we'll take a big breath in. And let it go. Breathing it in. And out. Breathing in. And out. One last big breath in. And release. And as we notice who we are, we want to acknowledge how we are feeling, what we're bringing into this day, and what we want to let go, what we want to learn, and who we want to be as we're here. I also want to take this time to acknowledge where we are. And I know that where we are is very different for all of us, but I am sitting in Sacramento. And so I'd like to tell you all about the history of Sacramento. History of the Sacramento area and the people is very rich in heritage, culture, and tradition. This area was and still is the tribal land of the Nisenan people. Sacramento was a gathering place for many local tribes who have lived throughout the Central Valley and the foothills for generations and were the original stewards of this land. We would like to acknowledge the Southern Maidu people to the north, the Valley and Plains Miwok peoples to the south of the American River, and we would also like to honor the Patwin Wintun peoples to the west of the Sacramento River. We acknowledge that we are standing or sitting on the tribal lands of Sacramento's indigenous people, and we want to thank them and acknowledge who and where we are. Right. And I would also like to acknowledge the amazing people that have made this summit possible. So you likely know all of these people already and love them as much as I do, but I'd like to throw a big shout out to Dr. Susan Timmer, Deanna Boys, Lindsay Armendariz, Colleen Allen, and Aubrey Johnson for their tireless help in making the summit work. You can see them all, say hi to them, send them a little private chat to say, I love you, you're awesome. And they will send one right back because we all love you and you are all awesome. I am Brandy Hawk down there at the corner. I'm a psychologist at the UC Davis Care Center and one of the co-developers of PC Care. Also be bringing you through our day and introducing you to lots of really amazing people. Okay, one of the cool things about doing virtual trainings and summits is that we get to interact in a very different way than we typically do. I think all of you are probably really good at Zoom by now, but I want to just give a few reminders. So annotate is a way that you can write on or stamp on a slide in front of you without it being on your computer. So we're going to practice annotating. If everyone can go up to the top of your screen, you'll see this view options. And when you click on view options, you'll see annotate. When you click annotate, you're going to have an annotate box that pops up. Go ahead and choose a stamp or an arrow or a drawing or a text and just write something on my screen. Beautiful. Excellent. Yay. Okay, I'm gonna say stop the drawing. You're all experts, clearly. And we're gonna go on to the next page, which is where the fun drawing is going to happen. All right. I wanna know where you are all from. So go ahead, take a stamp or whatever you want and show us where you are. We have a lot of folks from the United States. We also have some folks who are way more interesting places than right here. So go ahead and tell us where you are coming from. Everywhere. Turkey. That's amazing. All right. Wow, you guys are just coming from anywhere and everywhere. I love this. So we've got a lot of people in California, which makes sense. That's where we are too. But I love that we've got folks up and down the coast on the other side, places even outside of the US, Turkey. I know, Maria, I saw you here coming in from Spain. So I'm so excited to see everybody. And I want you all to know that this is your community. This is your PC Care community. It's not just the people sitting in the same building as you or even in the same city or state as you. You have people across the world who are here to support you. And that is something really, really cool. Okay, so this morning's agenda is going to start with Dr. Timmer talking to us about the foundations of PC Care. And then Dr. Marta Shin will speak to us on her keynote address at 9:30. We'll be taking a 10-minute break at 10:30. So that's a time for you to get up and do whatever you need. And then we'll come back together and talk about what we've just learned. So from 10:40 to 11:20, we'll be in small group breakout rooms. These groups will be about 6 to 7 people to really dive deeper into our knowledge of each other, our networking, and discussions about what we've heard about this day and our hopes and dreams and loves and things we want to see improve with PC Care. We'll come back at 11:20 and we'll have a large group discussion. And then we'll finish up at 11:40 by sort of putting it all together and building on our foundation. I recognize that all of these times are Pacific. And so if you are not in the Pacific time zone, they are wrong, but you can go with the 10s and 30s and 40s and 20s and see where we're going today. All right, and then just some quick reminders. Our chat bar is going to be monitored all day. I think another really great thing about a virtual training is that you are able to engage fully with the speaker and what's happening in the large group and engage within the chat bar. So continuously ask questions, make comments, talk to each other, talk to us. We will respond to any questions in the chat as quickly as possible, but please have a little bit of grace with us to know that we are monitoring and it might take a minute before we respond. We love seeing you and we would love to have you keep your video on when possible. We also know that sometimes it's not possible and that's okay. Please mute yourself when you're not speaking so that we don't get feedback or any odd voices or sounds coming in. And then totally fine if you need to take a break, just use your away icon if you leave, especially when we get into the second half of the morning with our breakout rooms so that people know where you are. And then one of the great things about this summit is that we're bringing people from across the world together who all care and love, who care about and love PC Care. So networking is a great opportunity here. And even though it's virtual, we want to support your networking here as well. So please email or chat Lindsay Armandaris or myself if you would like an introduction to someone that you meet at the summit. We can do an e-introduction for you. We are going to have about 45 minutes when the summit is over in the morning that you can set up a private lunch breakout room if you have a group of people who want to get together and spend a little bit of time talking, eating, drinking coffee, whatever. Let us know. We'll set up a breakout room for you, and then you can have that space to yourselves from 12 to 12:45. And then we'll talk more about work groups later. But if you are interested in diving in more deeply and becoming more involved in the creation and the dissemination and helping make PC Care even better than it is, and you would like to join a work group to meet more regularly with people in the community, please email Lindsay or myself and we can work on putting those together. And those are all of my reminders. And with that, I'm going to remove the beautiful hearts and stars and introduce you to my friend and colleague, Dr. Susan Timmer. Dr. Timmer is the Director of Mental Health Research at the Care Center, and she is one of the co-developers of PC Care. This whole thing was her idea. So she's the big wig, the biggest of the wigs, as we like to say. So Dr. Timmer, I would love to give you the stage.
Well, I just want to say thank you, Brandy, for making me laugh before I start talking, because we are always talking about how really I'm a very little wig. But anyway, you're going to start the PowerPoint, right, Brandy? Before I get started, I just want to acknowledge that my talk is going to be about the foundations of PC Care. And you might be wondering, why the heck is she talking about the foundations of PC Care at a summit where everybody is there because they know and like PC Care? Well, actually, there are a bunch of people in attendance that really don't know very much about PC Care at all. So really, in kind of celebration of the fact that they're here with us too, wanting to learn more, I thought I would go over some of the basics And besides, at the end, there is some stuff that you haven't heard yet. So, you know, we'll always have to save something good for you all. Next slide. Oh, that's me. I get to, now did I do what I was supposed to do, Brandy?
No, at the top, ask to take over remote control of the screen.
Okay, now I have all that annotation stuff up at the top. Okay, sorry guys. Oh, it's there anyway. Do you want to just do it, Brandy? And then
No problem at all. I got you.
Okay, thanks. So why in the world did we want to develop another new parenting intervention? You might well ask. There are a lot of very well-known, great interventions out there. And why develop another one? Well, you know, we, as you know, or you may not know, we came from the PCIT world. And if you're a PCIT person, you pretty much think PCIT rules. And we were looking at PCIT with this lovely combination of coaching and teaching and encouraging more positive parenting ideas. And we thought, you know, we want something like this, only a little different, because as wonderful as PCIT was, we were losing a lot of people over the course of treatment. I think we had attrition rates of over 50%. And I know, because I've talked to a lot of you all out there, that you all experience the same thing. So we thought, what the heck? Why couldn't we develop a short intervention that could appeal to parents and get similar outcomes and give them some behavioral management skills so they don't just leave PCIT with only pride skills, which are great, but we wanted to do more. We also were looking out in the world and seeing a couple of other things going on. One was a big push towards integrated care, or including mental health services in primary care. And PCIT was just really too darn long for that. I mean, we were a little nervous really that 6 sessions would be too long, but we didn't think we could do it in much less than that. And the other thing that was happening in the world was that services were being provided by a lot of different kind of people, not just mental health people or service providers, but people that were paraprofessionals, people that were home visitors. Those really were our frontline people. And we saw that those folks were not treated as well as mental health service providers, in the sense that they did not get the training that everybody else got. They kind of came in, got a little quick training, and then there was a high rate of turnover. So they would kind of do their best, get kind of burned out, and then leave. So we wanted something that could be structured enough that a paraprofessional could use it, you know, and didn't need a huge clinical degree in order to provide it. And so those kinds of things came together, and out of that, PC Care was born and developed. So that's, I just really pretty much talked about the first slide, but you know, I do that all the time. This PowerPoint thing is just a guideline for me, and I know that you guys are all friendly, and so you'll put up with me for that. I know Brandy's like, do I go forward? Do I go backwards? Well, you can go backwards. I'm going to talk a little bit about an overview of PC Care, the ingredients of PC Care, and last but not least, almost last, the evidence base. And that's where I have some cool new things. Okay, Brandy. All right, so now you know that I was the person that wrote my PowerPoint, because I truly did that first slide in the one before. The only thing I'll add to that is that we wanted to increase the age range of the kids that we provided services for. So we didn't want to be limited to 2 to 7, as everyone is always saying, oh, too bad that you can't provide services for my 10-year-old. And we thought, why couldn't we provide services to 10-year-olds? If 10-year-olds still like to play with their parents, And certainly the little guys under 2 could also be included in that group. We thought we could expand the age range and provide it to a larger group of people. Okay, Brandy, thanks. So bottom line, we wanted to create an intervention with structure and flexibility that could adjust to changing realities in our work environment, our cultural environment, using quality ingredients. Now, what are those ingredients, you might ask? Ta-da! And that looks like the making of something really delicious. I'm thinking like ratatouille, but anyway, just kidding. I just saw that picture and I thought it looked pretty wonderful. Next slide. In reality, here are our very fine ingredients for PC Care. One, we wanted to embed information about why the kids were having behavior problems. And we work a lot with traumatized kids and know that caregivers, whether they're bio parents or foster caregivers or relatives, really do not know that much about the effects of trauma on children. And they don't know that traumatic experiences predict a higher likelihood of having behavior problems. Kids' response to trauma is often externalizing behaviors and anxiety kind of behaviors. So we wanted to include that and kind of get the word out there that it's not you, it's not this child, because people make attributions about why children have behavior problems. And if they make an attribution like, this is just a bad kid, then it makes it really hard for that caregiver to be kind of generous of spirit, shall I say. So in addition, we wanted to have more transparency about what mental health services were all about. As we were thinking, if we could get people through PC Care, then they might be more receptive to also participating in other kinds of interventions. So we wanted to be clear about what would happen from week to week. We wanted to include the child in the intervention. We recognize that in PCIT, I mean, it's an intervention for parents and children together also, but the child is pretty much sidelined. And though sidelined, the child a lot of times has the ability to derail the session and possibly, you know, kind of reduce parents' enthusiasm for the intervention because they're not happy about being ignored or whatever the reason is. We wanted to include children in PC Care. We wanted to acknowledge that caregivers were the ones that were in charge. They were the ones that were living with the child. They were the ones to decide which skills they would use and which skills they would not use. And to kind of bully them and make them do something that they didn't want to do was a sort of a fruitless task. We thought it would be better with just a little bit of time to teach every week and then coach immediately about that thing, and teach only a little bit and coach a lot. And over the years, I have found, and possibly you all have too, that there's a really kind of strong need when you're a helping person to talk a lot and just explain things and try and rationalize things for the other person. And a lot of times people spend a little too much time talking and less time doing things that allow somebody to experience for themselves what you say to be true. So we just wanted to teach a little and coach a lot. We wanted to include calming and co-regulation skills, our fave, pride skills and strategies to manage behavior, snatched from PCIT. We, as you know, love live coaching and are firm believers in the fact that showing people what you're talking about is a really strong argument for doing. Focus on the dyad. So looking at the effect of what the parent does on the child, not just what the parent is doing. And for those of you whom I've trained, you know, I'm saying that all the time. It's like, oh my gosh, stop talking about that. But anyway, that's one of my big things. To connect up the causes of the behavior problems and the strategies that are working for the parents. So always keep them in mind of why they're there and why you're teaching them the things that you're teaching. And to notice what the parent likes to do and what seems to be working. So, okay, now this is the fun interactive part, and I can't wait to see this. This is going to produce a word cloud. So what we want you to do is to, maybe Brandy, how about you describe this? Because
Absolutely. So you can go on your computer or your phone to pollev.com/brandyhawk745. This is up at the top of your screen. And this will take you right to PolEV, which will give you a prompt that says, what's your favorite thing about PC Care? Just write in the 1 word or 2 words, and it's going to show up here. If you don't have the ability to get onto a computer right now, you can also text Brandy Hawk 745 to the number up above, and you can do it that way.
Oh yeah, Brandy, do you want to put the link in the chat?
Sorry,
That's a
I
good
just did
idea.
it, but in a direct message, not to everyone.
Would you mind erasing the hearts and stars too? I think a bunch of us accidentally started writing on the screen.
Yeah, sorry.
No
I know
problem.
I did. Really.
This is so awesome. I hope somebody takes a picture. Well, I know Deanna is recording this, but that's so awesome. Okay, I'm going to really talk quickly about the PC Care model. And if you don't, or you want to know more about PC Care, please, well, you'll have access to these, to the PowerPoint, and please get in touch with us. So very briefly, PC Care is for children 1 to 10 with mild and moderate behavioral symptoms or in other treatment, but family needs additional parenting support. We've had a lot of kids that are at the same time in TFCBT and other interventions, and or in a new placement or family situation. Brandy? A typical PC Care session looks like this: a brief check-in, a didactic where you teach new skills, an observational coding. It's a 4-minute coding. We put 5 because you have to give them instructions and wrap up. Coaching for 20 minutes, and check out where you review, assign homework, and assess for motivation. Next. And this is the course of treatment. Each session builds upon the next in the kind of amount of skill needed to perform the strategies. We start out with pride skills and repeat that at every session. Calming skills are in session 2, and those are repeated onward, and so on. You can see we introduce strategies to manage behavior kind of slowly from session 3 on. Sorry, thanks. Fidelity is important. You can see that it's well structured, but with live coaching in there, there's a lot of flexibility for therapists to kind of have their own voice, show their own personality. But at the end of the road, fidelity to the protocol is also important. So we have a lot of forms to help therapists and, well, I should say providers, help providers kind of stick to the program and know what they're supposed to do. There are checklists, there are coding sheets, there's training on how to do things and to see why it's important to do it that way. And now for the evidence base. We have an ongoing data collection in our clinic where we collect outcome information about the clients that are in PC care. And we have published an open trial paper on that data. Brandy has also been principal investigator of a randomized control trial, and she's just recently submitted the results of that study. That study took place in a primary care setting, so that's super cool. We are just in the 5th year now of a project funded by SAMHSA to provide PC care to 1 to 5-year-old children entering new foster placements. And I'll be giving you showing you results too. I'm not just saying this stuff. And then I did a little comparison of PCIT versus PC care, looking at the retention and the outcomes in the first 7 weeks of treatment. So in our clinic, I thought you might be interested in the kinds of kids that are getting referred. We have the full range of age, as you can see, from 1 to 10. Kind of the most kids are 2 to 3 and 5 to 6, with, some 4-year-olds in the middle. But really, the kids span the age range of eligible kids. We have about closer to half and half male female than in PCIT. PCIT was typically 2/3 male, 1/3 female, but here more females seem to be in treatment. And we have a lot of mostly bio parents, as in PCIT, but then a lot more resource parents or foster and relatives agree to participate in PC care, possibly because of its brevity. As the race and ethnic background, you can see is this is typical of our clinic. I know some of you all, especially down in Southern California, have a lot higher percentage of Latinx kids, but we have a sort of more even breakdown among the 3 major race and ethnic groups. And these are the findings of the changes from pre to post treatment on the IBERG intensity scale and the number of problems. You can see there's a significant shift from pre to post treatment, showing an improvement in behavior problems. I think the most really incredible thing that this open trial showed was a 90% retention rate. So you remember that one of the purposes of developing this intervention to begin with was to create something that parents and kids would want to participate in. And we felt as though this was a good length of time that people were willing to participate in this with 90% retention rate. And these just show the changes in WACB scores and also decrease in the avoid statements and increase in pride skills over the 6 weeks. See. Now, these are the findings for Brandy's RCT. And this shows that a more typical percentage of male to female people in treatment. But you can see that almost 3/4 of kids were male, and a larger percentage of white children participated in this intervention than we would find in our clinic. But remember, these kids were from the primary care setting, so it may be reflective of the kids that came to those outpatient clinics. And then the bar graphs show the change in the Basque externalizing scale. The red and the blue bars show the significant changes from pre to post treatment in the treatment group. And then the green and purple bars show the non-significant changes from pre to post wait list. As half of the group was assigned to a treatment group, half was assigned to a wait list group. So you can see that kind of similar pattern of significant change in the treatment group, in the BASC externalizing PSI total stress, and increase in adaptive functioning as measured by the BASC. This slide shows outcomes from our SAMHSA project in our work with foster kids. And here you can see the much larger group of African-American kids, as is typical of kids in a child welfare system. And you can see actually the caregiver's ethnicity too, a fairly large percentage of African-American, a large percentage of white caregivers, and kind of fewer Latinx caregivers than the kids in child welfare services. And here, these outcomes show, we were really proud of these outcomes, I'd have to say. The bar graphs on the top show the placement stability. This was one of our primary goals, was to stabilize the placement of these kids going into the child welfare system. Because in Sacramento County, anyway, that were 1 to 5 years old were getting switched, they were losing placements faster than any other age group, and much higher than California, state of California as a whole. So this shows you where kids were at 1 month after PC care or after dropping out of PC care, and where they were 6 months out of dropping out or completing PC care. And you can see a significant difference between the completers and the non-completers. Almost all the completers were in the same placement at 1 month, and a significantly higher percentage were also in the same placement at 6 months. And the bottom graph just shows the improvement in the WACB behavior problems from session 1 to 6. Now here is this secret, first hot off the press information that I'm just about to submit this paper for publication, and I thought you'd be interested in these differences that we found between PCIT and PC care. Now, you may or may not remember, some of you guys that have been around for a long time may remember our rules versus no rules study that we did. And what we did in that was to evaluate everybody's kind of progress in treatment in PC care at week 7 in comparison to pre-treatment. Well, we couldn't do this, unfortunately, but we could look at, I mean, it would have been so nice, but it did happen 5 years ago. So, but we thought, well, we can still use this same idea and compare PC care participants with PCIT participants and see how many, because we kept track of how long they were in treatment, thanks to, I have to shout out to Colleen and Aubrey for going in and finding out actually when people dropped, but we could see that a significantly greater number of people made it to 7 weeks in PC care or completed PC care in comparison to PCIT. So this shows, I'm kind of jumping all over the place. I'm sorry, I get a little too excited about the outcomes, but these kids are all EPSDT referrals. So they're all Medi-Cal funded low-income families, or they're connected with a child welfare service. So they're Medi-Cal eligible clients, whether they're PCIT or PC care. So in this, you see, we have a little bit lower retention rate among these EPSDT clients in PC care, but it's still significantly higher than PCIT. And I just kind of direct your attention to the percent complete 7 weeks, because obviously we're going to do better than PCIT providers who were there for, you know, between 12 and 20 weeks. there's just a lot more chance of them dropping out. But a comparison of how many make it to 7 weeks shows that teaching all those different strategies and kind of including all the elements that we talked about earlier in our fine ingredients may really help keep people in treatment a lot better. And this, the bottom graph shows that the changes, significant change in ECB scores from pre to session 7 in PCIT, which is kind of moving in the right direction, but it's not significant, and very likely because there's a lot of variability. But among the PC Care participants, you can see that change from a mean of 58 to down to 49 is significant. So we also accomplished keeping people in treatment and reducing problem behaviors in a short period of time. So stacking up against PCIT in a similar amount of time, PC Care looks pretty good. So in conclusion, we just want to reinforce that, and hopefully you already know this, that trauma and difficult life events, there are reasons why kids have behavior problems and need a parenting intervention, and that PC Care addresses these problem behaviors by improving caregivers' positive communication skills and providing all these wonderful ingredients that we talked about earlier, and that we found positive outcomes in our clinic at the care center, in a primary care setting, as a prevention intervention in our child welfare project, and in comparison with PCIT participants. And I want to just finish, not by saying that we see significant improvements in 6 weeks, because we showed that umpteen times, but by saying that even though we have a model we really like, we still are finding better ways to explain things and better handouts to support providers. And that's where you all can come in and help and kind of provide that continuous quality improvement that we are all about. Thank you very, very much. Thank you for putting up with me.
Thank you so much, Susan. This was a wonderful overview of our foundation. And I would like to transition from that beautiful foundation to introduce our keynote speaker this morning, Dr. Marta Shin. Dr. Marta Shin is a licensed clinical psychologist and research scientist. She is the Director of Training at the Child Guidance Center in Orange County, California, where she has overseen a large-scale implementation of PC Care. She is an experienced trainer in PC Care, PCIT, teacher-child interaction therapy, as well as the developer of family mealtime coaching. Not only is she a pioneer and an expert in the field of dyadic coaching, but Dr. Shin also serves as a psychology subject matter expert for the California Board of Psychology and the Association of State and Provincial Psychology Boards, and was a field trials collaborating investigator to the DSM-5. Dr. Shin is a Black Latina who is bilingual Spanish speaking and dedicated to culturally and linguistically informed psychological research and practice. I am privileged to call her a colleague and a friend, and I am so excited to learn more from her today. Dr. Shin.
Well, good morning, everybody. Great to see you all on Zoom and to hear your voices and read your messages in the chat box. I'm going to share my screen to get started, so give me a quick second to make the transition, but thank you for that lovely introduction, Dr. Hawk. So let's see if it'll let me. This is a way to test your technology skills in front of all your, did that work? I'm not sure if I'm sharing. Are you, can you give me a thumbs up, Brandy? You can see.
Yes, it just started.
Excellent. So you guys can see the welcome to the summit, and you know the name of the summit, and Dr. Timmer gave an excellent introduction to the foundations of PC care and all that. And so my talk is going to focus on building our community and an agency-wide implementation of PC care at the Child Guidance Center, which is where myself and my team are at. And so with that said, I just want to say that while I am the one delivering this keynote speech, there is no agency-wide implementation without my assistant directors, both Dr. Amy Weir and Dr. Elsa Torres, but very especially Dr. Weir, who is also a PC care provider and trainer and very experienced in the model. So both she and Dr. Torres were instrumental in making this agency-wide implementation possible. So that's what we're going to be talking about today, and how we, the Child Guidance Center, have participated in building the PC care community. So I will move on to the next slide. Let's see if it lets me do that. Boom. Okay, it did. So our objectives for today are to learn, one, we're going to learn effective means for enacting a PC care trainer of trainers model in a community-based setting, because Child Guidance Center is an outpatient community-based setting. We're a nonprofit and we serve children birth to 21. And so what I'm going to be sharing with you is how we accomplished it and the steps that we took. Specifically, we're going to talk about how to apply a TOT training into telehealth, because we are now in the age of telehealth. And so we're going to talk about, well, how do we do this all virtually, both from training all the way to provision of care? And then overall, we're going to acquire an understanding of the perceptions that PC care trainees like you and trainers have, and adapting both to the needs of providers that they're training and the diverse client population that we work with at the Child Guidance Center, which is similar to the Care Center. We're a little bit more in the percentage of having a greater percentage of Latin families or Hispanic families. So you met the PC care team a little bit earlier. You met your developers, Dr. Susan Timmer, Dr. Brandy Hawk, Lindsay Armendariz, and we also are including on this slide other people who participated in CGC's PC care training, Elizabeth Mota Garcia and Katie Martins, which is in the bottom row. So you see that top row is your UC Davis care team, inclusive of Katie Martins, who's at the bottom. But I also, even though they weren't actively involved in the direct training at CGC, want to acknowledge Deanna Boyce, who's always behind the scenes, always available, and really is the backbone of many things that we do, as well as Colleen and Aubrey Johnson. And last but not least, a shout out to Dr. Urquiza for his leadership in everything at the Care Center, including PC care. And then in the bottom row there, you see myself, I'm Dr. Marcia Shin, Dr. Amy Weir, being thoughtful, and Dr. Elsa Torres. And so you'll hear more about Dr. Torres later. So keep that mental image in mind, because she's gonna make an appearance a little later on. So that is our PC care team, so that you can meet everyone. And they're all here today as well. So let's jump into setting the base for our TOT model, or training of trainers. So what is it? So the Centers for Disease Control defines TOT as having several objectives. If you look at the graphic to the right of your screen, you see that the TOT is intended to start with an individual or a small cohort of people, and then it's supposed to expand out throughout an organization to achieve sustainability. And so its intended goals are that senior trainers, previously referred to as master trainers, will engage in coaching new trainers that are less experienced on a particular skill or topic. And then one of the main goals is that trainers, instructors, providers of different sorts, once they receive that level of training from the senior trainer through the TOT process, that they too will participate in training their own cohorts and effectively reinforcing the skills, in our case, coaching. And lastly, that the key outcome is sustainability. I do want to say this, that we are going to have a Q&A toward the end, but if you would like to ask a question, feel free to chat that in the chat box, and the people who are monitoring it will alert me that you have a question. I'm happy to address questions throughout to make this a more of a conversation, even though it is a keynote. So with that, so how do we apply a TOT model to PC care specifically? How does that look within PC care? So that graphic to the right is actually the CDC's graphic for the components of a TOT and what it involves. And to the left, you see a description of what it looked like in the implementation at the Child Guidance Center with the UC Davis care team of developers. So that first step was to engage the care team with the UC Davis developers and all of their certified trainers. And then secondly, we worked to identify our training cohort within the agency to determine who are those people. And I'll talk a little bit more about that in upcoming slides. That cohort then was trained by certified trainers and went through both phase 1 and 2, and then each of the specialized population appendices. With their trainer, the trainees watched their trainers teach the skills, they completed exercises, they practiced coding, they practiced with team members in their cohort, all in an effort to prepare them to start services with their dyads, with the children and family that they would, caregivers that they would be working with. And then lastly, once they acquired those baseline skills, then they went ahead and the providers in training conducted sessions with the dyads and received either live or recorded review of those sessions with their trainers. They were signed off on competencies, and then they were supported weekly by way of prep calls to make sure that they were prepared. And then because TOT is an ongoing process, we repeat that process with the trainer. So think of this as just the first step, and then we're going to continue to repeat that until we achieve what you saw on that previous slide to the right, so that we are doing that. So what that next slide described was that first step, knowing that we're going to be doing that with multiple cohorts. So how exactly are we structured at CGC? I wanted you to see that TOT is not just a philosophy, but it's the way that, or a way of training. It's also a way to structure training within an agency or organization. So this is the structure of our training department, which really begins at the top and to the left of your screen. So you see there that it begins at the top with the administration and the CEO really buying into a TOT structure. Our CEO, Lori Pack, is really committed to making sure that we have that for the sustainability of programs at our agency. Within our agency, I oversee training as the director. And as I mentioned earlier, I'm assisted by Dr. Weir and Torres. And then we have a team of clinical supervisors at the top who engage in TOT training for our interns, our graduate students in the master's program, and pre-doctoral and postdoctoral interns. And then you see at the bottom that that's our EBP track. We have there our senior trainers, Dr. Jose Cholula Bruno, who you'll meet today throughout the day. Others involved in our evidence-based practices, including TOTs like Cynthia Johnson. And then from there, we have our PC care trainers, our PCIT trainers, our TFCBT clinical leads and certified trainers as well. And then last but most importantly, our training assistants who are headed by Christina Amio and the rest of the team there. So you see that we really have a structure built within the agency that we've intentionally laid out in order to have a TOT structure within our agency. And I wanted to give you that visual because that's important to the work that we do. So now let's talk about launching PC care within the agency. How did we do that? And we didn't launch a rocket, but we thought it was a cute visual to describe, especially since we're preparing to have women go on the moon. And so here are the next consideration is how to fund an implementation project. So these are some of the things that we did and things for you to consider. We leveraged existing funding sources that had training dollars. So we have contracts that had training components, and we asked, could we apply those to be used for PC Care training? And we had specific training only grants that I'll talk about a little bit later. We used direct service contracts, including our Medi-Cal program and EPDSDT, and then you can consider applying for specific grants just so that you can disseminate PC Care or donations. I know a lot of organizations like us also have. I think someone is unmuted and is speaking, so if you can mute yourself, please. All right, so how exactly did we do it at CGC? If you look at the graphic to the left, while the graphic of a money tree is cute, and I thought it was really fun, that's not how we funded it. So how did exactly we go about funding training in PC Care? The answer is multiple sources. Firstly, we secured a grant that we wrote through CalOptima, who is essentially an administrator of Medi-Cal services, and they are sort of like an HMO and had grants specifically for young children, which we applied for and were awarded. We also use existing training funds. One specifically was, we have a grant through the Orange County Healthcare Agency called the Behavioral Health Training Collaborative with partner agencies. And we use that funding to pay for phase 1 training, the 7 weeks of didactic training, and then ongoing training in PC Care through the appendices and starting of live coaching. And then the live coaching sessions, those 7 weeks beginning with pre-treatment, were funded by way of the Medi-Cal program and then the CalOptima grant, which funded direct services. And so you see that it really takes more than thinking about what services you have and what resources you have, but supplementing that with other things potentially. All right, so then what were some preparation steps that we took and how did we incorporate telehealth? So the first thing, as I mentioned earlier, is that we worked on selecting the cohort. So how exactly did we do that? In our agency, because we are a mental health agency, our providers are at this stage of the process, all mental health providers, which means they are either master's level or doctoral level types of providers. And we did this intentionally, even though we have bachelor level providers, because we understood that that first cohort of providers would likely be our trainer. And so we wanted it to include people who had experience with EBTs in order to participate in that. And so to that second bullet point, you see that our targeted recruitment really looked at who are these individual providers who have experience with evidence-based practices and what is their availability to work with a PC Care client population, meaning are they interested in working with children? That's really critical for PC Care because of the 1 to 10 age range, and making sure that these are providers that are comfortable. And then because they were our first cohort, we wanted to make sure that most of the people in our cohort had an interest in training others so that they could be part of that TOT process with us. And then we also required that people had prior approval from their program directors to participate in the training. That's really important because training directors and clinical supervisors who know their staff understand what requirements and responsibilities they have and how those staff members are doing in meeting those requirements. So we didn't want to put people into PC Care training that, for example, were struggling to meet their productivity within other programs and then add more work. So if people were really not at a place to participate, we didn't include them at that point, not forever, but just for the immediate cohort, and then we could revisit for later cohorts. And then we wanted to make sure that people had the availability to participate in the skill building workshop, just plainly their schedule and their calendar, that they weren't anticipating that they would be out of the office on vacation for several consecutive weeks. during the 7 weeks of training, pre and then also for the coaching. And then we wanted to make sure that they had the ability to recruit participants in order to participate in that phase 2 and therefore meet their certification process requirements. So really that cohort selection is something that we took very seriously and is critical to establishing a PC Care program. I'll pause here in case there are any questions in the chat box or things that people would like to speak up to voice and ask.
We do not have any current questions in the chat.
Excellent. Thank you for that, Brandy. So I'll proceed to our next slide. So what does PC Care look like? So to the left, you see that pre-COVID, there you see Dr. Hawk. She's presenting to our group. Herself and Lindsay Armanderas came down to Southern California. They flew down, and in January 2020, we did phase 1 training, an all-day training on that. And so that's there. Soon after that, you see we went to where we are today, where we're on a fully virtual format and we're training virtually and providing services virtually. So that is where we are. That's where we were then, and this is where we are now. And so to prepare our providers for that, thanks to Dr. Hawk from the Care Center, she created a PC Care via telehealth how-to training video, and you see her there smiling and sharing all important tips. If you guys have not watched that training video, you should. It's about under 15 minutes, and it really covers all the basics of how to deliver PC Care via telehealth. And Dr. Hawk really explains things thoroughly there, and so we required that our staff, prior to commencing services, both training and provision of care through telehealth, that they view that training video, which is pre-recorded, and also we hosted trainings to specifically prepare them on more things related to virtual dissemination or implementation of PC Care. And then we also help them understand what modifications there might need given that we were during COVID. And so while there had been telehealth prior to COVID, we hadn't done this as like, hey, this is our exclusive way of providing care. So we really had to prepare our providers for that and make sure that we were addressing their questions and apprehensions and their fears about, will this work to make it 100% virtual? I know it's convenient and we have to for health reasons, but will this work? And so those were genuine questions that our providers asked us. And so we were very diligent about preparing them to jump into that. All right, so what were the provider experiences? So this is from Dr. Davis, and we asked our providers, well, in preparation for this talk, well, what did you think? So Dr. Davis is from our original cohort and also in the CalOptima grant. That's her emoji. So she's waving hi to all of you. And she shared that most of the caregivers that she worked with found it convenient. They found that being on Zoom decreased the amount of time that it required to complete treatment because it was more accessible. The families were more motivated, and especially because the changes were more immediate. And as far as connection goes, she expressed that she thought that the caregiver connection with their children was positive, and she really appreciated that the model supported nurturing through positive play. So that was from Dr. Davis. And well, our next question is, we understand what you all think because you guys are believers in PC Care and you know all the evidence that Dr. Timmer shared about its effectiveness. And you guys are all trained in PC Care, so it makes sense that providers would say, of course it works. But what would the kids say? Are children connecting with their provider on telehealth? So this is a brief video. It's conducted, just to give you a little bit of context, it's conducted during daily care. We asked this caregiver to record their daily care with us, and we got this wonderful clip that we thought you would enjoy watching. So here you go.
Where's Dr. Torres? Dr. Torres is not here today, Mommy. Okay, so? I want to talk to Dr. Torres. We'll talk to her later.
So you see in that video, Lola there is missing Dr. Torres, who's her provider for PC care. And while it was daily care that this mom is doing for her 5 minutes daily, Lola really got connected to Dr. Torres. And so I thought it was really cute that she mentioned her and really was understood that, you know, these coaching sessions happened with Dr. Torres. I think that part of what confused her was the fact that mom was recording for us. So she assumed Dr. Torres would be on the screen as well. But nonetheless, it was a really touching moment to see how connected she was through her provider, who she's never met in person and has only interacted with by way of telehealth. So thought you all would enjoy that. All right, so next thing, jumping into, now that we know that kids connected and providers thought that it worked, what were some of the training expectations, regressing back to thinking about training that we set up for our cohort to make it successful? Well, we were very clear about the expectations that we had for them. We outlined exactly how much time investment they would need total in training, and we let them know each of the phases of treatment and anticipation of the training and how much time they could expect to spend in PC care on a weekly basis. So while I'm not going to read that slide to you, we were very careful to share this with our providers before they started the cohort so that they understood that this was not going to be a one-day training and then they were done. This was going to be something that was going to be highly supportive, of high quality, but would require a significant time investment on that part. And we found that when providers went into the process understanding that, they were better able to prepare their schedule or to be honest about the fact that, wow, if I want to do a good job at PC care, I need to carve out the time in my schedule in order to do this. And so that was one of the things that we shared with them. So we also explained that there would be competencies and that we would be checking off their competencies, that these competencies there would be competencies related to skill building, related to their didactic skills and teaching the caregivers, their process of conducting the coaching and didactic sessions, and then their overall coaching competence, and that we would be signing off on it, and that they had to complete 2 cases with fidelity. So we took the time to explain to them what competency looked like so that they understood. We don't like to, when training in PC care, to say, well, there are competencies, but you can't know what those are. So we like to review those ahead of time with our providers so that they know, and so that they know what we're looking for, they understand what constitutes fidelity to the model, and they can prepare for it so that they can be successful. So then how do we track those competencies at our agencies? Like at the care center, we use Basecamp, and we use it to track competencies, but we also explain to our providers how to track their own competencies. So while trainees can't sign off their own competencies, we do expect them to track onto them, to have the Basecamp app on their smartphone if they use a smartphone, to have a way of accessing it on their laptop or desktop, and to see where their completed competencies are housed and what we expect them to do. It's also where we place progress notes and where we expect them to upload things for their trainer to see. And so we really take time to make sure that they understand how to use the system so that they can use it effectively. And last but not least, we do have PC care training progress notes. These were developed by the Care Center, and we implement the use of these, again, for tracking of competencies, for providing written feedback, for documenting our work as trainers, and also for providing specific feedback to our trainees on how they're coming along and what areas they can continue to improve in. So what were some of our training achievements? Well, we had a large amount of participation. As you can see, our phase 1, which is that skill building, consisted of 27 participants. And that number is much larger than who you see going through the first cohort, because we understood that for us, phase one was about identifying the cohort and that not everyone would be a good fit to participate in phase two, but we wanted to ask all those important questions of the 27 people who had met our criteria and who would be appropriate to go through this first cohort, as I shared earlier. So 15 people went through that first cohort, did all of the session two, phase two workshops, and then completed all the special populations or the appendices. And so the numbers that you see on here, that 14, 11, 14, and 8, those were the people that attended live. And the rest of the people in the cohort, the 15, also attended the appendices. They might have just watched the video afterward, because we understood that not everyone was able to, everyone had committed for phase two, but the appendices, we were a little bit more flexible. So we recorded that and then hosted that a little later for people who had schedule conflicts. So those are our numbers on there. And then here you see our trainee hours. That in fact, that is what we expected, and that's exactly what we did. People participated in approximately 37 hours of training throughout the course of their training, inclusive of phase 1, 2, the special populations, the prep sessions, the live or recorded supervision and feedback, and then documentation and certification processes. So before we get into provision of direct services, I want to take a moment to check in case, Dr. Hawk, we have any questions or comments.
We did. We had a question from Don Hamilton asking about if you have any info or guidance on training paraprofessionals.
Yeah, so this particular presentation is about our first cohort, which did not include paraprofessionals, and but we have paraprofessionals within the agency who expressed interest in phase 1, and we will be training them. And as a matter of fact, we're training another agency that is not paraprofessionals, but they are not clinicians. And so I know that that doesn't give you very specifics about the successes or challenges, lessons learned with that. I don't have those as of yet, but it is something that we're intending to do within our agency.
Yeah, we also have a question from Andy Gonzalez asking, were the training cohort participants otherwise incentivized to participate for retention purposes?
Great question. So as you saw, we did secure funding. And so the funding paid for the Cal Optima positions that we had. And so that was helpful, but we didn't have additional funding to provide stipends. So in other implementation of other EBPs, specifically PCIT, we had funding to give stipends for people once they completed PCIT training, but we didn't have that for here. The incentive was that they would be in the first cohort and would be the first step in the TOT process and would have an opportunity to be among the first to be trained in the model, among the first to be certified, and to participate in that trainer cohort. But we didn't have any monetary incentive, and we didn't have any incentive as it pertained to reduction of DISH either. So meaning productivity, we call it DISH, but there was no reduction in any of their responsibilities. So that's why we had to be particularly careful, because we weren't able to say, oh, well, you can stop doing this in order to participate in PC care training. So know that we totally understand if you're in a similar situation, and you'll see that despite not having additional funding or ability to stipend or reduction of other work responsibilities, that we still had significant success with our cohort and in people that were quite committed to the training process.
Thank you. I think that's all of our questions for right now.
Excellent. And then if there are follow-up questions to that from anyone, we will have Q&A at the end, and I'm happy to clarify or expand later on. All right. So then what did client recruitment look like? In in terms of the client recruitment, we developed our own What is PC Care flyer in both English and Spanish, which you'll see a little image of later on. We prepared a PC Care recruitment training, first in English, and then our providers translated it to Spanish so that we could recruit in the community. We shared about PC Care in all of our partner meetings and networking meetings, which we attend a lot of. And then our Cal Optima providers, namely Dr. Davis and Dr. Cholula, conducted community outreach at community meetings, schools, CFT meetings, and the meaning of that leaves me right now, but it'll come back to me, and all locations where we thought that we would have access to young children in the PC Care age range. So we conducted a lot of community presentations and recruitment to get the word out that, hey, we're the first agency in Orange County conducting PC Care, and we would love to provide services to your children and families. So on this next slide, you'll see what our PC Care flyer looks like. The language is very similar to the flyer developed by the Care Center. Main difference is that our version includes our logo, our contact information for our intake coordinator, and our funder. So you see that there. And we included at the bottom of the flyer, I'll show you again where it looks like here at the bottom of the flyer, we added each of the weeks because we were getting a lot of questions to our intake coordinator about, okay, I know what PC Care is, and I know who it's for and who's eligible, but what are you doing in these 6 weeks? So we're like, you know what? We're going to put that on the flyer. And so here's a little close-up of what's at the bottom of the flyer. It's everything that you saw in the PowerPoint Dr. Timmer showed with the process of treatment. We just spelled it out for the parents in these cute blocks at the bottom, and we put it in English and Spanish so that both referring parties and caregivers would understand what skills we would cover each week. And then this is an image of our recruitment PowerPoint. We developed a PowerPoint entitled Improving Caregiver Relationships Through Parent-Child Care. And we presented all the components of PC Care so that people could understand who was appropriate, how they could refer to us, how to contact us. And our team of trainers and providers use this PowerPoint throughout the community, both in English and Spanish, to really get the word out about what we were doing and are doing at the agency. So what was the training experience like for our providers? So Dr. Davis shared that with regard to telehealth, that she thought it was beneficial being able to study the modules at her own pace because we did have recordings. So we conducted things live, and then we allowed our providers to review if they felt like it, each of the modules, to go back to the recording to reference it, both for the 7 weeks and for practice coding, as you see in that second bullet point that Dr. Davis shared, that having ability to practice that coding really helped improve her efficacy and confidence in doing it. And then she really appreciated both the live supervision that we provided because that improved her confidence. So at our agency, once we got going with training, we did observe live and then only reviewed videos when we weren't able to join live. But our trainees understood that, you know, if we're able to join you live, we will, particularly for the first case, so we can sign off competencies as we go, and so that we could message providers live and say, hey, here are some tips, here's what you can consider. And they had more of that live training from us, but that wasn't always feasible given everyone's schedule. So we did also record and provide video review paired with those progress notes and prep calls. And then here is our other Cal Optima PC Care provider, Dr. Jose Cholula. And to the right, you'll see the key points that he discusses, but I'll play the video so that you can hear what his impressions were with telehealth services.
For the different phases, I think it really made a huge difference in regards to the learning process. I really feel that phase 1, it really helped me just really fully understand the roots and the grasp of PC Care services. And really phase 2, it really helped me specialize more individual needs for the client, but even for myself. And the reason why I say that is because in the process, as I was learning, I was trying to think and analyze for myself what are some methods that I can do. Here at CGC, we particularly work with Spanish-speaking families. And as a result, I really want to make it relevant and meaningful for some of the Spanish-speaking families. So as we went through the second phase, I really try to see what are some ways that I can do to help and support the families that we work with. And the trainings that we had for specialized populations did that. And that was pretty amazing. And it was nice how it almost seems like a different phases in regards to the training perspective, where we learn the tools and strategies, we apply the strategies, and then we specialize it to the strategies, to the needs that we need as providers.
Well, I played that video for you because who could have said it better than Dr. Chulu? I thank you for all his work at the agency and very specifically with PC Care. He's just a fantastic team member and great to have him be one of our providers. And so that was his experience and we appreciate him sharing that. So what about the families? What are families saying about PC Care? And so let's hear from a family. So this video is again of our Lola, who missed Dr. Torres in our first video. And just to give you a little bit of context, Lola at the start of PC Care was about 33 months old. She's currently 35 months old. She is verbal, so you heard she can speak and all that, but she's a little a toddler, and her mom and she participated in PC Care with Dr. Torres. As I shared earlier, they've never met in person. All of the training has been conducted through telehealth. And so all of the coaching and the didactic training has been done that way. And so this is her mom sharing, and Lola a little bit sharing how Dr. Torres helped them and what they learned in PC Care.
What did we learn from Dr. Torres, Lola? We learned how to say please. Please. Thank you. Thank you. We learned how to share with mommy. Share how to mommy. Okay. No. Good job. So what did I learn in PC Care? Basically, it has helped our relationship and made her more calm. I learned to speak calmly so that she responds to me calmly, and use encouraging language, such as please. And I like the way you did that, saying, we have 5 more minutes left of this. And then we're going to do something else, okay? Okay. Okay, so in warning her of what's going to happen is another thing that has helped, because then when it's time to end, she's not going to be shocked. And she's more calm overall. She used to have tantrums. She doesn't have tantrums anymore now that we've been communicating. So that's really what PC training has done for me.
All right, so that's spoken by Lola's mom, Denise. And as you can see there, it's exactly what we would have expected. She was not coached on what to say. So I was really impressed to hear all the things that she learned and how she was really helped by Dr. Torres, even things like that it improved their relationship. And you can see Lola is, you know, a PC Care expert herself at this point and was giving her a ta-da, like, please praise me, so that her mom can share a praise with her. And so I think that it's really a nice example of what can be done in PC care and also what can be achieved solely through telehealth. And whereas as a profession of behavioral health workers and mental health workers, we've initially expressed a lot of apprehension about, well, could this work? Could families learn the skills? Could this be done exclusively on telehealth? I think the current circumstance this past year with COVID has really caused us to think about that and be in a circumstance where that was our primary mode of delivery. And so people really fine-tune the process, and I'm really proud of the excellent work that Dr. Torres and our team have done with families, because the improvements really show, as this mom nicely stated. So with that, let's talk a little bit about what were the lessons learned from our agency-wide implementation at the Child Guidance Center. So our key takeaways is that it's really important to define a training model first, because that's key to success. If you just jump in and you don't have a plan of how you're going to do this, both in the short term and in the long term, then you have the potential to dedicate important resources to PC care training, but not have a sustainable model. And we all know that having a sustainable model within the agency is really important to keeping things going and to make sure that your investment is deeply rooted within the organization and takes hold, so that you have multiple generations of PC care providers that are available to provide services to families. Next, it's important to identify a funding source both for training and for services, and to leverage existing funding that you do have and speak to those funders about how you'd like to use those funds for PC care training, because this is a very unique model for a specific age range, serving very young children, which many models don't in the same way. Most models that start at age 1 are really tailored to work directly with the caregiver, but not engage families in the same way that PC care does. And we want to have the opportunity to coach Lola, and that young children as early as 12 months can participate in learning behavioral regulation skills and emotional regulation skills by way of PC care. Next, we learned that it's important to think about at the outset of the process who your TOT trainees will be and who will be in that first cohort, because they are the seeds that will grow your PC care tree. And your program will blossom if you're very thoughtful about who to include in those first cohorts, and for that matter, ongoing cohorts. And last but not least is that, you know, change is part of the process. I think it's been a lesson of this past year that COVID has disrupted a lot of things for us, but there have been many silver linings. And I must say, for me as the training director at CGC, this has been one of them, for me to recognize that whereas in previous years and other implementations of other EBPs, I really relied heavily on that in-person contact and being able to meet with my team and and have that in-person connection and meet with new trainees. That this year really helped me understand this could be done all virtually. It could be done effectively. We can have good outcomes, and we can start virtually only. And so I feel very encouraged that going forward, once we're able to meet in person, we'll really be able to integrate these things. So I hope that these key takeaways that we learned and these lessons will be helpful to you. And I'd like to end by giving a quote from Audrey Hepburn. She said that to plant a garden is to believe in tomorrow. And so I thought that was a beautiful quote that someone else shared for inclusion in this presentation. But I really loved it because I think it speaks to the work ahead of us in PC care. We are in fact building a foundation, we're planting seeds. And the fact that we're planting these PC care seeds is because we believe in the garden and we believe that it will flourish in our tomorrows. And so I thank you very much for your attention. We will do a Q&A with the remaining time, and that's our contact information. We can share that our email in the chat box if you'd like to connect with our training department, and those are our references. But I thank you very much.
Thank you so much, Dr. Shin. I will applaud you for everybody. We had a few really wonderful questions for you in the chat bar. And I think the one thing that everybody wants is to know if they can receive a copy of the recruitment handout that you've developed.
We are happy to share that. I don't know that we don't have it at a link where I can share it in the link, but maybe we can work on creating a link, or I'll make sure to share it with the UC Davis care team so that they can send it out in a follow-up email, or however they'll share resources from the summit. We'll get you a copy so that you can have a copy of the handouts and use that. Feel free to use any language that you like, in English and Spanish, and make it your own.
Thank you. And we'll be happy to send that around to everybody for sure. I would like to allow anyone to unmute themselves to ask a question directly if you have one, and I'll also look in the chat to ask any that I have missed. We're seeing a lot of great jobs.
Thank you. Oh, I should look at the chat box too. So thank you, everybody. I see them now. Beautiful. Well, I appreciate everyone's feedback.
Oh, here we have a great question from Melissa Pace. What was the time frame from beginning to consider PC care training until the first implementation?
Well, that for me was a longer process, because not described in this PowerPoint is that I had to be trained in PC care. And so I was trained by Dr. Hawk and Dr. Timmer. And so I have a longstanding relationship for many, many years by way of PCIT and other projects with the UC Davis care team. And so we've been in discussions, at least me with Dr. Timmer, for years from the very beginning. But it took a while from learning about it and working together on all thinking through the training model and them starting to disseminate for me to do it. But first, before this cohort started the previous year, so that was January 2020 and 2019, I did my own PC care training with Dr. Hawk and went through all the stages and completed my competencies and training with my dyads. And so I would say once I completed it, it was just a matter of like, let's make this happen. And once we secured funding, we're like, okay, we're doing it. And we were just picking a date. So it was relatively quickly from the time that I was ready and we had secured funding, we got started right away. It was literally just logistics. And the care team is really excellent about that. If you reach out to them, they're pretty good about giving you a sense of when they can get started with training with you. And now, with the phase 1 being on Zoom, those are happening regularly. I want to say, Dr. Hawk, about every couple months, you guys are doing a phase 1, right?
Yes, we try to do them about quarterly, including one coming up on the 30th of March.
Awesome. So special plug for the next phase 1. You can certainly join that. What we did is, because we were going to have a whole agency dissemination, we had them do a phase 1 just for us and phase 2 and appendices, but you can certainly join the ongoing ones that are offered quarterly. Great question.
Thank you. We have another question from Colleen Allen. When selecting the first TOT trainees, what qualities did you look for?
For me, the main thing outside of the things that were listed in the PowerPoint is that they genuinely had an interest with working with young children. As a child psychologist, I know that children are very perceptive. They may not have language, but they know if people want to be there and if people enjoy working with them. And so for me, the main sort of character quality or personality quality that I wanted the providers to have was a genuine interest in working with young children and an enjoyment for doing that, followed by having had a track record of demonstrating that they could be responsible with requirements of meeting competencies and things of that nature, whatever their responsibilities were, because these were providers that were all within our agency, but they were in different programs. So we had to assess for their individual program requirements, you know, how were they doing? And so that was really critical because past behavior is the best indicator of future behavior. If you have staff people that are really struggling to stay afloat, but you really like them because they're a great person, and you sign them up to do PC care training, it sets them up for frustration and yourself, because they're likely going to repeat that cycle in their PC care training, where if they're struggling with other responsibilities, they will also with PC care. So I think those were the top two among others.
And generally being wonderful people that you want to be with.
Right. People that we want to have in our PC care family.
We have another question. How much did the CGC program work with UC Davis in developing the TOT?
Well, like I said, we have such a long relationship that it's not isolated to PC care. You know, UC Davis has trained our agency in PCIT and TFCBT. So the care team and specifically Dr. Timmer have been very instrumental in helping us structure our training processes so that it fit within that TOT model. And so I think they've been a great example for us, and Dr. Timmer has been a great mentor and friend to me. And so she's been very instrumental in helping me understand how to implement a TOT. And she's a resource when I had questions like how to do this. She's been there for me and guiding me in how to set it up. So before we started the process and before I started meeting with my team to figure out how to do it at our agency, it involved conversations directly with her and others at the care center and meetings to talk about what would that look like. So I would say for you all, I think, you know, you should take at least a month to 2 months to meet with your agency leadership to, if you want to start a TOT process for PC care and for other EBPs, to really have that conversation, to read the CDC information on what TOT is, to get educated on it, and then to get educated on PC care so you could really prepare everyone to have buy-in and to support you with the process.
Well, thank you so much, Dr. Shin, for this incredibly informative and helpful presentation. I see nothing but wonderful responses from everybody in the chat. And I'm sure that you would likely be happy to have people reach out with any additional questions.
Yes, I'd love to hear from you. So you can reach out directly to me I'll display that. You can contact the training at CGC. That's our general email, and it goes to myself, Dr. Weir, and Dr. Torres, or you can contact me directly at M for Marta and then Shin, my last name, same ending. So M Shin at the same ending. So if you want to take a picture of that, you're welcome to do that and reach out to me. But I think a lot of you, I see a lot of familiar faces. So you guys have my email, you know how to reach me.
Thank you, everyone. Please join me in a big round of applause and thanks for Dr. Shin. I am going to take back the screen. And I would also just like to say that we are only 5 minutes over on our virtual training, which if this was in person, I think we'd be at least 20 minutes over. So, you know, we're doing great. We're